She holds 3 patents on the use of sensor and data acquisition technology to measure and characterize hands-on clinical skills. In 2011, Dr. Pugh received the Presidential Early Career Award for scientists and engineers from President Barack Obama at the White House. In 2014, she was invited to give a TED Med talk on potential uses of technology to transform how we measure clinical skills. In 2018, Dr. Pugh was inducted into the American Institute for Medical and Biomedical Engineering. She was also elected a member of the National Academy of Medicine in 2021 for pioneering sensor technology research that helped to define, characterize, and inspire new and innovative performance metrics and data analysis strategies for the emerging field of digital healthcare. So thank you so much for being with us, Dr. Pugh. We really appreciate it. It's hard to think of a person more qualified to give this talk than you. So we thank you again, and I will turn it over to you.
Well, thanks everyone for the opportunity to share a few thoughts and experiences here. I'll pull up my slides and get going. So my talk that I was asked to speak on is best practices for simulation. And that really put a smile on my face. And immediately I thought, well, what would I talk about? And I thought the first thing, definitely a reflection on key events that really were learning points for me as I have spent a number of years collaborating and performing research in this space. And the second thing I would do is share with you some of the simulation-based assessments that we've used and developed and learned from during the course of our research. And so starting with the reflection, and I definitely want to be provocative because learning is sometimes very revealing and painful here. But when I step back and think about getting a PhD in education, and the biggest epiphany I had there was the correlation between the history of K through 12 education and surgical education. And it really, one part of that history centers on this, the lecture, how the learned imparts knowledge to those who desire to have more knowledge. And it was very interesting to jump into simulation and start to integrate that and be there when you're, some of the first to integrate it into the curriculum. And you get your team together and you do a lot of work to set up the, get the sim scenario, what were the learning objectives, and then have the faculty come and stand in front of the simulator and give a lecture. And they're like, that wasn't the plan. And so then, obviously then you had to do teacher training, right? And so that was the sort of next evolution in the realization that the faculty had to be taught how to use the simulation and to integrate it into their own knowledge so that they can impart additional knowledge. And that was the hope. And then obviously progressing to where learners actually have hands-on use of the simulations, whether with faculty feedback or guidance. And I think this is a memorable point for me, just transitioning from the lecture mindset to a hands-on and integrating both. Obviously, bringing a new technology on board doesn't eliminate the other, but really getting to what we wanted to achieve with simulation required teacher training and teacher education. The other thing, and this is actually a picture from one of the first simulation courses that I put on with the faculty at Northwestern in my first faculty position. And so all the medical students here are actually performing a digital rectal exam with a sensor-enabled simulator. So we put sensors inside of a Limbs and Things model. They all had different anatomy. And the instructor demonstrated on one simulator how to do the exam and what you would see on the computer screen in terms of feedback regarding your digital palpation. And so you see all the students looking at the computer screen as they're performing a digital rectal exam. And in the early stages, we called this purely sort of the teaching mode, where we allowed the students to see the screen. And then when we turned the screen away, and recorded what they were doing with their finger movements, the force profile, and where they were touching. We call that the assessment mode. But now that I fully understand how the mind works and how training works, I would say that this is a combination of what I would call formative self-assessment, because the students read in a book, they, many of them have maybe performed an exam or two, maybe not these students, actually, I think these are first year students. But what they're doing is doing the exam as they think it should be performed, and then they're looking at what the computer screen is telling them. So they're actually doing a formative self-assessment in this process. What it also enabled, this screen showing the areas where people are touching and with how much pressure, it allowed peer evaluation and shared learning, which was really interesting. And so I think that when I look back, I think that there's more opportunities to invoke formative self-assessment and definitely peer evaluation in the process. And we did some small studies with that and just were amazed to see how the students received each other's feedback and wanted to play that role. Another scenario, in the assessment mode, if a faculty is standing there from your perspective and completing a checklist, that's, really sort of what we call more of a formal assessment. But, what do you call this here? This person is, the faculty person is definitely giving real-time feedback, and I think that, this can be on the continuum, relating to, faculty and resident partnerships around learning. And so I think that this teaching versus assessment is a little more fluid now that we have, more structured frameworks in terms of formative versus summative assessments and how we use it and how we set it up, which guide how people interact with one another. But these were foundational learning experiences for me in terms of how you set up a simulation, how you set up it for teaching, and how you do it for assessment. And so the other topic relates to validity. And it was so interesting, I think, for in the very beginnings of this, and thinking about this 20 years ago, we talked a lot about whether the simulator was valid or not. And I know that may make some people feel quite ill when I say those terms, but that was the language that we used. And after a while, it really evolved that we began to understand that we weren't really validating the simulator per se in and of itself, but we wanted validity evidence with respect to the assessment that we were doing. And so in the beginning, some of this language was still not as well defined. And I think one of the key papers for me that was super exciting was this one paper, the BME systematic review, that really had a major review of over 600 simulation articles, narrowed it down to 100, and then ended up with the 10 key features of medical simulations that lead to effective learning. And so I'll get into that because that was also very interesting. The other one was really getting the language, what does it really mean for validity, reliability, and just accepting that you're getting validity evidence, and validity is not something that you establish the validity of the simulator, but that you're gathering validity evidence, and it's a continuous thing, and that it's not something that's done, in the past or that's ever finalized, but there's an opportunity as soon as you get a new learner or a new learning environment or new learning objectives, that this is a requirement is that it's something that's constant. And definitely the standards for educational and psychological testing really added more to our understanding and global implementation of assessments, and really the understanding of validity evidence and all of the forms of reliability and validity. So it was just, this was really sort of a key moment. And I think one of the other things that was guiding some of this was, the pushback from major organizations, including our own medical school systems, where we all, as instructors and researchers are like, this is great, this is the best thing since sliced bread, we should adopt it. And they're like, well, why should we pay for this? And how do you know that it really works? You have to prove it. And so it really kind of boiled down to a cost consideration. And if we're going to pay for something and pay that price, to implement it, whether it's all medical students or residents, we have to know that it's scalable and it's has going to make a difference in our education endeavors. I wanted to focus a little bit on this paper because this was written over 15 years ago, I believe. Maybe, yeah, I didn't put the date here, but I think it was 2006, if I remember correctly. But there were 10 features that they came up with, and the top 3, well, just focus and pause on the top 1, that, and a feature and use of a simulation that led to effective learning. It's feedback. And it was just kind of a grounding thing that was super exciting to have. We sort of felt like we knew that, but just to have it, shown in an empirical fashion, and then repetitive practice, and then integration in the curriculum. And we know, if you think of these top 3, this was it. I mean, you could build the best simulation scenario in the curriculum, but if you couldn't integrate it and get the learners there, then you just weren't going to have a major effect on your program. And so then when you look at the bottom 3, I'm not going to go through all 10, but the bottom 3, individualized learning, where learners are active participants and not passive bystanders, defined outcomes, that you had an outcome measure, something that you wanted the learner to master or achieve, and then validity. And this is where it comes in, which is so interesting. At this point in time, we were still blending the two. We were still validating simulators, and we hadn't really focused on the fact that what you're seeing on the right side of the screen, or the left side of the screen, really relates to teaching and learning, which was the goal of the paper, effective learning. But on this side, it actually was really more shifting more towards learning and assessment. And there's a difference there, right? Because this paper was about effective learning. It was not about objective assessment of skills. And so if this review was done again and the focus was objective assessment, then I think that validity evidence, like that your assessment has some validity evidence, and it relates to your defined outcomes, and it enables self-assessment and peer. So you can't do self-assessment if you don't have any metrics or an assessment to perform it with. I mean, you can try, you want to teach yourself, but you kind of have to have a set of defined outcomes and an assessment that has some validity evidence and applicability for individualized learning to actually take place. So this also sort of really kind of gelled my thoughts in terms of what are you really after, and what questions are we addressing, and how really are you using simulation in terms of a best practice? How are you situating it for success, whether it's for learning or whether it's for assessing skills? And those are two different things. This was one of my other sort of epiphanies, realizations, and almost a panic, in that I realized at some point we were spending a lot of time and a lot of effort assessing residents, which is appropriate, right? This is our product that we want to make sure that they finish our programs with a certain skill set and a knowledge base. But at some point I began to feel like we were assessing the residents in a vacuum. You have the instructors and you have the students, and then you're comparing these two. But it's really the instructor filling out the checklist who's deciding who performed one way, and that's appropriate to a certain degree. But when you step back and look at that from a process perspective, what we were really doing was putting our education activities within a very traditional assessment framework. And that traditional framework, with or without simulation, was that there was someone who was an quote unquote expert who had all the knowledge. And they were the ones that then decided in a subjective manner whether you met the bar or not, and whether it was time for you to move on to the next stage. It was based on human observation, and that is one way, but it's not truly objective if you actually don't have the metrics of this person and the actual desired outcome, such that you have true metrics and criterion performance that you want the trainee to meet. So that was the inspiration for my focus on assessment, because I thought that we could do more. I thought that we could get data from practicing clinicians and use it for criterion performance. And what you're seeing here is a series of different simulations, porcine intestines, porcine heart valve, and we've done other simulations, which I'll share in the next 10 to 15 minutes, using a variety of sensors, EEG sensors, motion tracking sensors under the glove here. This is EEG data, this is motion data. This is also real-time motion data synchronized with a video. And as we've used this approach, we've really gained a lot of insight into the heuristics, the thought process, the decisions, cognitive decisions, as well as technical decisions, as well as technical skills of practicing clinicians. And I'll share a little bit of that with you today. Yeah, one example in technical, a cognitive example, and then mastery. Again, these are some of the data streams that we are capturing when we instrument a clinician while they are performing a procedure on a simulator. And this is a close-up of the magnetic motion tracking technology. The first centimeter is actually the sensing unit, and the rest of it is a wired system that goes to a data acquisition unit to collect the movement data. And what I'm going to show you here, these two surgeons are wearing the motion tracking system, and this person is a fellow, and this person is a 20-year veteran attending, and this is a microvascular anastomosis. And the fellow makes a critical mistake in the beginning of the procedure where they begin to tie the knot and they pull their suture tail out of the view of the microscope. And then they have a very large working volume chasing that long suture tail around. Oh, sorry. And so note the working volume, note the little bit of a tremor and how fast they're moving compared to the more experienced clinician. And there's that suture tail out of the view. And then you've got to chase that. The attending does the exact opposite. He pulls the tying suture out and leaves the tail here. And this working volume of tying knots is much smaller than this. And this person's finished. So imagine trying to, and the suture here looks great. They got the suture in, it's just the knot tying that had some issues. Imagine trying to give feedback to this fellow. They can't hear you, right? Because they're like, my suture looks great. What do you complain about? Oh, you're having a bad day. Like, and they're saying in their head, obviously they're not portraying disrespectful fellows, but they can't hear you because they know how to put the stitch in. But the knot tying isn't as efficient as it could be, and it actually could cause problems. But they'd be more in a position to hear you if you show them this. So this is the motion pattern of those 3 suture throws, the knot ties, I'm sorry, the knot tying, the 3 knots. Percent completion, so the blue or darker blue areas, that's the first knot throw. The green is the second, the yellow is the third. This is chasing that long suture tail around to tie that first knot. Then you're chasing it again and then chasing it again here. And so now you have a visual benchmark of what a more experienced controlled knot tying looks like. And so this fellow now can then go practice and see that, but also now can hear better than someone just giving them verbal feedback. And the interesting thing here is that this is not a technical skill. This fellow knows how to tie a knot. And in fact, some of the faculty, when you're tired, you may make some of these mistakes. You know, you're tired and not paying attention. But what we've learned is that a faculty person, many experienced faculty, will cut the suture shorter. If they accidentally pull the tail long, they'll cut it short to the length that they want and throw the other end away. So faculty don't accept inferior circumstances, but fellows and trainees that are still in the learning curve to mastery accept inferior circumstances in terms of their vision and the OR and other things that they just don't know. So this is a rule-based error. And it doesn't take 1,000 hours of training to undo this. Once they see this data and they go back and look at the video, they just enact the rule. And so I think that when you step back and look at how we use simulation and how we talk about them, sometimes there's this overtone or thought that there's, you know, it's really to train technical skills when there's a lot more to it. And what we're finding in some is that the rule-based errors are a lot more common than we think. And so think about if you could eliminate a majority of the rule-based errors, then you could focus more on those things that do actually need some dexterity training and other type of technical and cognitive. You have more cognitive load and resources to address other things. I'll give one cognitive example. This one relates to perception. And what we do know is that when we've looked at the data, we note that experienced surgeons adjust what they do according to how the tissues respond to them. And so we want to see if we could capture that in detail with the motion tracking technology. And so we presented to experienced surgeons, residents, and students 3 different common household materials, and said that you need to put 3 sutures in this material. And what we're really looking at, again, is their perception. What would it take to put 3 sutures, you know, in foam material versus balloon, rubber balloon, and tissue paper? And we had them put 3 sutures in each of those 3 materials. Obviously, the faculty were more efficient in doing that just by comparison. But what was interesting is regardless of what group you were in, everyone spent more time on the tissue paper. And that's because everyone had some perception that you can't use the same technique that you do on foam and balloon and not tear the tissue. So there's some type of you know, a construct in terms of our perception of different materials or tissues and what it would take to do that. And it shows that you can put a Prolene suture in tissue paper. What was interesting was that this was the first needle hole, and it's larger and it got smaller with each one. And so and the amount of idle time and pausing decreased between each suture as the surgeon gathered information in terms of what it took to get the needle through without tearing the tissue. Then you become more effective. And so it was interesting to see this serial adoption. The other thing we noted when we looked across the participants was that when we looked at the number of idle periods per step of this placing a suture, and this is for the tissue paper, that the students have more idle periods when entering the tissue with the needle. The residents had more idle periods when driving the needle through the tissue, or pulling the needle out, and the faculty had more idle periods when tying the knot. And so it just goes to show you that there's differences in the strategy that can be found when looking at motion data. And what we realized with this is that not only the motions matter, but idle time and idle periods do matter. And what we learned is that it not only correlates with skill level, but it also correlates with task difficulty. And those moments when people are idle relate to surgical planning, decision-making, information gathering. And we also noted that in a separate study of residents who were in the lab, after their second year in the lab, that they had more idle periods at certain decision points where they hadn't fully mastered. They went into the lab and now they're having to think more. And so there was some skills decay that could be detected by the location and the length of the idle periods within a procedure. Last example related to mastery. In 2019, we partnered on my research lab, which is the Techie Center. We partnered with the American College of Surgeons and put on what we called the Surgical Metrics Project, where we actually set up 10 simulated OR stations in the main exhibit hall of the Clinical Congress, and over 250 surgeons lined up and allowed us to put sensors on them while they addressed this specific scenario. They had about 1.5 feet of porcine intestines that had a standardized injury. And we created an engineering way of fabricating a standard injury for all of the intestines, where there was a large hole next to a really small hole. And we did it on purpose because we wanted to see how many would make the decision to cut the tissue in between and then just do one repair. And this is a picture where you can sort of see the little hole there and then this larger hole in the bowel. And the scenario we gave them was that you just finished a 2-hour license of adhesions, and now you're running the bowel looking for enterotomies. And we did not tell them whether there were enterotomies or where they were or how many. And so that began the scenario. We started with the whole group here. We did actually, in our first evaluation of this data, we actually eliminated a fair number of people. Some of them had incomplete data sets, either the video or a sensor failed. This is our first time doing a mass data collection with the sensor technology for surgeons. We also excluded those who missed an injury, because in this first analysis, we actually wanted to look at the techniques and decisions of those who actually did the repair. And then we wanted to assess whether they leaked or not. Those who leaked because they missed an injury, that's a different failure mode. So that's a separate evaluation. But what we found is that for those who found both injuries, the majority of them repaired them individually, but it was interesting that the few of them, the 28 of them repaired them together, and those who repaired it together had a lower leak rate. This is a technical decision. This is not a technical skill that we know of, really. And then we looked at whether they did a double layer or single layer repair. Most did a single layer repair, which is probably the norm, but the double layer repair had a lower leak rate. Single layer repair, it didn't matter whether you did running or interrupted. There was no significant difference in the leak rate. But if you did interrupted and you didn't put a corner stitch at the beginning and end of your repair, it turns out that you had greater than 50% leak rate. And then we began to be curious, because if you look at this, these are the persons that are on the riskiest pathway. The good thing is that you can be on the riskiest pathway and it's not 100% that you're going to have a leak. But then we were curious, even in this small n, who are the people who are on the riskiest pathway but still didn't leak? Like, that's some level of mastery, right? That you can be on the riskiest pathway and not leak. So what was the difference? And this is the corner stitches. So this is now the people who did not put a corner stitch in the bowel before they did the repair of this in between. And it turns out that they had almost 1.5 times more suture throws. They put more suture in that space, in the seam space. And they tended to assist themselves more with their left or right hand, have more bimanual dexterity, which we believe for those surgeons that they have a little less cognitive load and more cognitive resources to make other difficult decisions when they're assisting themselves. And this keeps popping up in a number of different simulation scenarios, the bimanual dexterity, and it's pretty interesting. But when we step back and look at the study, it's just interesting. This is just how I do it. These are surgeons who say, I always do a double layer repair, or, I make my decision based on how the tissue responds to me. And so there's all these different scenarios. Overall, when you look at it, the leak rate wasn't extremely high, but I mean, if you compare it to, I should say this scenario actually represents what we do on the table. This is not a leak rate for a patient in the postoperative period. This is after you've done your repair, we tend to squeeze the bowel on the table. And if there's air or fluid comes out, we put another stitch in. Well, that's a whole nother study. There were some 1-stitch leaks and there were some 3-stitch leaks. But we didn't, just because of the amount of time, we didn't allow them to repair the leak and then do a second leak test. But that was, sort of interesting that 70% didn't leak, but 30% did. And then you start to boil down like what's happening there. Our summary from this particular study was that, idiosyncratic approaches, or how I do it, can be quantified and shown to have measurable effects on procedural outcomes in a simulation environment. But it's another sort of measure, of mastery. We never really thought about this. We always looked at the technical skills and not so much the technical decisions. And a lot of these just aren't measured. And we think that, this is just the way that I was trained. This is the East Coast way or my way. And so we were excited to find another set of metrics or ways of looking at things that can help us with our training of residents. I just wanted to share a little bit of the data, or at least a visual of the data of the EEG sensor, which, because it doesn't require sterilization, I can wear it in the operating room. And this is what my brain looks like during an appendectomy. And we go back because we time sync the EEG data with the video. When you look along here, it turns out that the darker red areas are when you're identifying important anatomy, and then here you're cutting across it. And then this segment is hemostasis. And I wear the same sensor the same day during the appendectomy. Here I'm actually speaking to a resident and listening to them as they're telling me, how much of this procedure they've done before and what they want to do in this case. So this is actually, this dark red here is a negotiation with a resident. The other space here is coming across the cystic artery and duct and then getting hemostasis on the liver. And so I think when you think about having this type of sensor, track your deep thought during a procedure and then being able to go back to that point in time in a surgical video when you're giving a resident feedback, that allows for another different use of a video in the OR or in a simulation in terms of feedback. It's very difficult to give every pointer that you want to give real time, but to have this type of biomarker as a automated register of important points during a case is also another opportunity with simulation. I think in the end, it goes back to that BME study in terms of effective uses of simulation, and it goes back to feedback. And I think if I had to settle on one thing, that is what I would say is sort of the best use of simulation really is for that feedback. And whether it's, feedback from your esteemed attending or faculty member, self-assessment or peer feedback, I think that this is the way to go, whether you're on the learning curve to competency or to mastery. And so that would be my take-home message from my reflection of my experience using simulation in our profession. So hands-on learning with feedback, allowance for self-peer and faculty assessment, and then criterion-based assessments. I really think that we are lacking a large volume of databases from faculty benchmarks and procedural outcomes that we can use to really track the learning curve for residents and allow them to be proficient self-assessors and peer assessors. Well, thank you.
Awesome. Thank you so much. That was a really excellent talk. I learned a lot, and that research is really fascinating, and I want to hear more about it later. We have about 20 minutes left, so we should have time for a pretty robust Q&A, so put your thinking caps on. While we get started with the Q&A, Rebecca's going to drop a link to a quick survey in the chat. And once the seminar is over and the Q&A is done, if you don't mind filling that questionnaire out, it helps us to provide feedback to our speakers. Dr. Pugh, I know, would appreciate that, as well as to plan future seminars, which hit on topics that you all are interested in. So With that, I'll go ahead and open the floor for questions.
I'll go first for everybody who's okay. Carla, great talk. Benson Dana from Boston Jones. I really enjoyed your talk and followed your work over the past several years. And my question to you would be, how do you see us moving toward employing some of these assessment metrics that are great to be done in the Sim Center and for research purposes, to incorporate them more with sort of these more common sort of workplace-based assessments, such as like SIMPL or operative performance assessments, to add a little more granularity, or even if not every day, but like intermittently in the clinical setting, to get to these decisions of okay, how do we decide if this fellow or resident is competent to move on to the next level, in terms of incorporating these metrics to this sort of competency-based assessment sort of framework that a lot of us are interested in, that we sort of have a hard time putting it into practice with the available tools that we have.
Yeah, no, I love that question, and I think that's definitely the end goal. And ironically, we our team and I just got that opportunity from Stanford Healthcare to translate what we've done in the SIM environment with these wearable sensors to the point of care. And so we've gotten started with that in the past couple of months, and it's been very interesting. The faculty are definitely willing to wear the sensors. And I think, in your question, we still focus on the residents, but again, if we don't have the faculty benchmark for that, then we still, I think, are assessing the residents and faculty in a vacuum. And so I think it requires a partnership. I think that and what we're finding is that it works. If the faculty lead the process and are willing to be assessed, then the residents are greatly appreciative, and they'll participate and help to drive, getting their own feedback. But right now, we've in our first pilot, we did it for 26 cases over 7 different faculty, and they wore the EEG sensor in the OR, and we synchronized it with their video from a variety of laparoscopic cases. And so now we have EEG signals, and in some instances of a faculty, a resident, and a student. And it correlates with not only with what you're thinking, but the EEG signal changes when you are operating and adding sort of motor control to that. So we could actually already tell just from looking at the EEG sensor when the resident's operating versus when a faculty is operating in an automated fashion within 30 minutes after the case. And so I think that I think there's a huge opportunity there, but again, I still think that it begins with the faculty. I think at a national level, the reality, as we sit here and talk about, like you said, the research and the fun and the data, once we start getting in the operating room, and actually before that, and we're starting now, we are going to have to lobby Congress for protection of our ability to use this data for teaching, and for feedback and for quality, because it doesn't help anybody if this data becomes discoverable. And so I've stood on that totem pole a number of times just to make it very clear to all involved. I mean, for patients want the best physicians that they could have, but that doesn't work. You can't burn the candle at both ends. That you want to then use that very data against the surgeon, that could actually help them to be the best that they can be. You want to use that against them in a lawsuit. So we have to do work in that space. And so we're partnering with the college, AHRQ. They have some federal laws in place, but there's also state laws that are incomplete. And so there's a lot of loopholes in this space. I've met with the congresswoman in my district and their staffers, and they get it. But it goes both ways. Everybody wants data, but then everybody's there's also the fear of the data in terms of how it, being used against you, and that will lose control. And it's like, well, the reality is that many of the medical devices have this data already. And if they're the ones that lead this, we're going to be in trouble.
How do you envision giving feedback based on that EEG data? Like, oh, you're not paying attention, you're not thinking correctly, your mind's all over the place, or hot, or that EEG data seems like, how do you
use
it?
It really is a biomarker to find the moment in the video that's of importance.
Oh, I see.
It does give you an understanding of what's happening in the video as well, but it's still a biomarker for tagging the video. So you've got a 4-hour operation. Nobody wants to review that. You want to go to the parts where people are thinking the most, or frustrated, or focusing on something important, and definitely where the attending is super cool, relaxed, and the resident's super stressed. You're like, okay, that's a learning moment right there. So you can the 10 seconds before and 10 seconds afterwards in that video and know exactly, that's a critical learning point.
Okay.
Excellent. I think we have another question in the audience. Amir, I don't know if I've said your name correctly, but yes.
It's quite all right, it's Amir. But thank you, Dr. P, for the very fantastic, fascinating talk. We do some research. I'm calling from Imperial College in London. There are some, shall we say, similarities between what you're doing and what we're trying to research, however, in neurosurgery, so slightly different fields, as it were. And I have some questions regarding 3 things, really. Firstly, what Dr. Sandeas was asking about. Have you found a good way of anonymizing the data that you collect from the residents and from the attendings? Because obviously, sorry, again?
Is that a good way of itemizing?
Anonymizing it.
And yes.
Yeah. So that one. And have you done any kind of long-term studies as to how the feedback helps the residents in their progression versus those who haven't had that sort of feedback? And thirdly, what are some of the methodologies that you're looking at to assess or quantify the expertise? Are you using machine learning, for example, or any kind of linear regression, or any kind of this kind of data or analysis methods?
Yeah, no, great. So we, it's sort of, we went down the sort of anonymizing, decision tree, because we never we'll give that individual their feedback and their data, but we don't share data across people, and I don't present. So I show my own data, but I leave it up to that person if they want to share it with someone else. So for the resident, all they know is that these are the learning points for you based on your data. And because of the timing, I think one of the persons said, well, likely if they know, if you show their data stream plus the faculty's data stream plus a student, then they're going to know which case it was, or they can reverse engineer it. But it's sort of like you're reverse engineering it so you can know who you were operating with, but you still don't have their data. So we don't share the data. We don't share each other's data, and we only look at pooled data in terms of giving the feedback in that moment per case. But yeah, we definitely, the goal is to maintain anonymity. It doesn't help anyone in the process that if we are sharing individual surgeon data. But as the database grows, for you to then be able to see where your benchmark compared to a group, then you're understanding where you may be an outlier in certain areas, and that's a learning point. But yeah, we don't share that. If they want to share and compete, that's up to them. Long-term feedback effects. We don't have long-term feedback effects, but definitely some short-term feedback effects. And the most dramatic ones really relate to the rule-based errors that people make. And it's just, we have videos of it, and it's just amazing to look at. The one that's popping in my head right now was a fellow who was doing a lap ventral hernia repair, and pulled the transfascial suture through the same hole, and then went to grab the mesh, and the mesh kept dropping. And it was just it was a rule-based error. And so those are, you know, but just for that person to go through, watch the video and say, yeah, I'm not sure why that's happening. And then we point out, and there was like, wow, you think about what's missed when you're observing someone, you're thinking that you're doing exactly what they're doing, but they missed that there was one incision, but they angle this way to pull up one, and then you angle that way to pull up the other. And that little part was dismissed. And so the epiphanies are pretty dramatic when people realize the rule-based errors. I think we haven't really had the study or the financing to do like a longitudinal, you know, implementation within a program and do continuous assessment. And the focus of most of our work has actually been to build the databases of experienced practitioners. So more of our workflow is taking our SIM-based scenarios to an exhibit hall and getting data from 200, 300 people and then understanding the variety of decisions. So yeah, there will be those opportunities in the future. I think as our data continue to mature, and then the more databases that we have, then there'll be programs and hospitals that want, you know, to have that as a benchmark. Yeah, but right now, you know, I mean, we all know on this, I don't have to preach to the choir, getting funding, you know, to do all the projects you want to do is in education spaces it's a labor of love at a minimum. So your other question related, yes, we are using machine learning, linear regression, all the above. We have a number of data scientists in the lab as well as in the greater campus, and we share data, and we are publishing one of our first data sets that we are publishing with a group with Mackay, with the engineering groups who want to, you know, train some of their ML algorithms and computer vision and even deep learning. So there's a lot of that going on. And I think the fun for us is to sort of blend the biomarkers of the wearable sensors with that also, if you think about it, is really a form of annotation, automated annotation. So it can help streamline some of the assessment. Thanks.
Thank you very much.
Excellent. We've got time for a couple more questions. Joe, I see that your hand is raised.
Great, thanks, Becky. Hey, Dr. Pugh, thanks again for being with us today. My question is about this study you conducted at Clinical Congress. Really interesting stuff. My question is really about confounding experience with operative decisions. So the first branch of whether to repair the injuries together or separately, intern Joe would not have considered repairing them together at all. Mid-level resident Joe might have, and I'm sure senior residents and attendings definitely considered it. Could any of these differences in leak rate be related to the experience level attendings versus residents rather than the decision itself? Essentially, how did the decisions between residents and attendings differ at each of those points?
I love the question. And so the first answer to that is there were no attendings in the data. There were no residents. I'm sorry. There were no residents in the data that I showed you. These were all attendings.
Wow. Okay. Interesting.
So we only allowed residents to participate when the line was short, but mostly we actually had the residents go and get their faculty and bring them to the study because they were helping us. They know that if we don't have the faculty's actually performance, then we don't have, you know, a benchmark. And so the most of the residents actually would bring their faculty to us, but all of that data, those are practicing clinicians. And so when you get into the decisions, it's very interesting. So usually the line of questions I get, what people say, well, porcine bowel, they're all different and they're not the same as human intestines. And I'm like, yeah, but there's a range. It represents a fair range in the same that you would see in human anatomy, whether you get an enterotomy from chronically obstructed bowel or, you know, Crohn's bowel or whatever have you. Our bowel varies as well. And the reality is that some surgeons adjusted their decisions based on the bowel and what it looked like and how it responded, and others may have done what they usually do. But the good part about it was that we presented a standardized scenario to 250 surgeons, and most of them got through it, but they just made very different decisions. And I think that it's a fair representation of what really happens in clinical practice. And for those, what we would really look for is the outliers, right? For those who, for example, there was only two people who leaked who repaired it together. We have to look at what those, I mean, it's a small N, right? But if you get a bigger study of the 28 people who cut the tissue in between and repaired the injury together, only of the 28 people, only 2 leaked. What did they do wrong? Like those are outliers within that group that made that decision. And so there's an opportunity there potentially. It was just too small. We didn't spend the time looking at those videos, but it's more of a heuristics example. It's not, the reality check for us is that there is not one exact right answer and not one right way to do this, but within the groups of ways, there's some things that are best practices within those. And so, I can't compare someone who did interrupted and a single layer to someone who joined it together. Like those are 2 different decisions. And so you got to do apples to apples and oranges to oranges, and then look for outliers within those subgroups. But I don't know if that really answered your question, but it's clear that people make different decisions, and mostly those decisions are okay until it's not in the very end, which is 50% leak rate with those who don't put anchoring sutures when you're doing interrupted. That's a big deal.
Sure, got it. Thanks, Dr. Pugh. It did. Thank you.
All right, we've got time probably for one more question. All right, I do have a question that might help you get, like, I don't know, I'm interested to hear what you have to say, but you kind of alluded to this at the beginning. But I'm curious as a learner and, hopefully an educator in my future, what you see as the appropriate balance, if there is one, for measuring like teaching and learning versus learning and assessment in the simulation space. And the way that I kind of think about that is, what's the appropriate balance of formative assessment and of summative assessment?
Yeah, I mean, the interesting thing, my first thought to that is that it really maps onto the continuum of the learner's goals and then the program's requirements. So usually, with a formative assessment, that's usually, a summative, with a summative assessment, that usually gets into programmatic requirements, right? I need to know that you've reached this level before I can say you move on to this skill. It's for making decisions, similar to like board certification. That, if you're not certified, then that makes it, you can't practice your craft. And so I think that that's sort of the high level traditional kind of answer. When I think about formative, I think that the majority of things would be formative, but there's different types of formative assessment. Is your own formative assessment of yourself as you're learning to make sure that you're doing it right according to what you thought the task should be and the outcome. And then the next level is pulling in your peer, who can then give you feedback and say, no, I understood it to be this, or, and then I did it this way and I got this outcome. And that creates a community of learning. Then having that faculty give feedback, someone who's, the most experienced and knows what the outcome should be. I think that then takes the formative assessment to another level. It's a little more high stakes formative when you're then now in front of your faculty person. Even if it's not summative, it's not documented. I think that you feel like you've gotten a more confirmatory write-off on your skill set in that moment when you finally go to a faculty person who has more experience than you. So I think the majority of what we should do is formative. But, as I mentioned, in terms of being purposeful in doing that and setting it up, and I think where one of our weaknesses is we don't do much peer assessment as much as we could. And I think it's super valuable.
Well, I love that you ended on that, because I definitely think, any space that you can create as a safe space for learning and collaboration, especially between peers, is just such a important part of training. So thank you for saying that. And, thank you so much for your seminar, and for everyone else who has engaged and participated in this time. We really appreciate your time. Again, please fill out our survey in the chat. And don't forget to mark your calendars for our next seminar, which is going to be on June 7th. Dr. Gergen will be giving a presentation on how to write an outstanding op-ed piece, and you definitely don't want to miss it. So we'll look forward to seeing you there. And with that, we'll close on out.
Thanks, everybody.
Thank you.
Thanks.